Good morning. My name is Dr Echivard. I'm working in the University Hospital in Nancy, and I'm really happy to introduce this work entitled "Predicting Heart Failure Events in Patients with Persistent Ventricular Dysfunction After Acute Myocardial Infarction." This is an insight, a second analysis of the WICD-MI trial. I think the background really matters here. After MI, some patients can suffer from left ventricular dysfunction, and in these patients, it's recommended to reassess LVAF in 40 to 90 days. And for what reason? Not to stratify the heart failure risk, but to stratify the risk of sudden cardiac death and to determine whether they need an ICD implantation, depending on how LVAF evolves. And these patients may also benefit from a WCD setup during this waiting period. So I think we can obviously say that in these patients, the current management is primarily focused on preventing life-threatening ventricular arrhythmia. However, in patients with persistent left ventricular dysfunction after the early post-MI phase, at time of ICD implantation, which is finally a common situation in current practice, in clinical practice, we have so far no data regarding the heart failure risk, and therefore how to stratify this risk. This is finally the second analysis of the WICD-MI trial. The first article was published last September in the European Heart Journal. We analyzed 1,015 patients from 41 fresh centers with first an acute myocardial infarction, then a WCD setup at discharge because of a left ventricular dysfunction, and finally an ICD implantation, either in primary or in secondary prevention, but with a low, persistent left ventricular dysfunction. The follow-up was the first year after ICD implantation, and the primary outcome was a composite outcome of heart failure events, namely heart failure hospitalization, left ventricular assist device implantation, heart transplantation, and death. And we aim first to quantify this risk during the first year after ICD implantation, and then to stratify this risk. But stratify with a simple hypothesis that heart failure begets heart failure. We want to determine whether clinical heart failure features before ICD implantation could predict heart failure events after ICD implantation. First of all, heart failure events in these patients with persistent left ventricular dysfunction is clearly frequent. It's a frequent issue. The 1 year risk after ICD implantation of the primary outcome is 12.7%. The risk of heart failure hospitalization alone during this first year, close to 10%. And what is striking, really interesting, is to couple that to the risk of ventricular arrhythmia, 5%. So the heart failure risk during this first year after ICD implantation is almost twice as high as ventricular arrhythmia risk. Then we confirm that HF begets HF. Using only 4 simple clinical heart failure features between MI and ICD implantation could predict the risk of heart failure events after ICD implantation, namely cardiac shock during MI requiring vasopressor ECMO, congestive heart failure during MI requiring diuretics, hospitalization for worsening heart failure during the WCD period, and finally dyspnea and YHA 3 or 4 at time of ICD implantation. All these 4 features are independently associated with the primary outcome. And finally, we aim to build an easy-to-use score. Really an easy-to-use score in clinical practice, 1 point for each of these 4 features, and it enables to clearly distinguish low and high-risk patients. Patients with 0 points or 0 feature, 5% risk of primary outcome during the first year. Patients with 3 or 4 features, 3 or 4 points, 38% of risk during the first year of ICD implantation. And this predictive value remains across all secondary outcomes like heart failure hospitalization or death. In terms of clinical applications, it would probably improve the multidisciplinary management between arrhythmia specialist and heart failure specialist. It could help arrhythmia specialist at time of ICD implantations to identify high-risk patients and to early refer them to heart failure specialist. Then, and it's a little bit the same idea of timely referral, it could facilitate timely referral to tertiary centers for advanced heart failure management. And third, finally, it could improve the use of DDMT implementation. Three key findings. First, in this patient with persistent left ventricular dysfunction after the early post-MI phase, heart failure is clearly a frequent issue. Then, using only 4 simple heart failure clinical features between MI and ICT implantations could predict the risk of heart failure events after ICT implantation, namely cardiac shock during MI, congestive heart failure during MI, hospitalization for worsening heart failure during the WCD period, and finally, NYHA 3 or 4 dyspnea at time of ICT implantation. And finally, use this easy-to-use score, this simple score, to identify high-risk patients and to timely to early refer them to heart failure specialist or test service center for advanced heart failure management. The next step would to validate this easy-to-use score in a larger cohort and to determine whether the use of this score in clinical practice would improve patients' outcomes.